Good morning.
Good morning. Good evening from India, Professor.
Wow, India. This is remarkable, the technology, isn't it? Here you are in India, like if you were next door.
Absolutely.
Well, I'm delighted that the technology is working. I was worried I haven't had a Zoom from India yet, so I was hoping.
It's a great honor to have you, Professor. Looking forward to this meeting. The technical team is doing the necessary formalities of. I said the technical team is doing the necessary formalities of getting things live on YouTube also. In the meanwhile, we'll start at 6:30 sharp.
Okay.
सर मैंने वो किया मगर मुझे यहाँ पे मैसेज आ रहा है योर ब्राउजर कांट प्ले दिस वीडियो
Sarita, mute yourself.
उसको एक मैसेज आ रहा है योर ब्राउजर कांट प्ले दिस
Sarita, can you mute yourself?
पता नहीं बिंदु लगा दी फोन ना
ओके हाँ
Good evening and welcome, Professor Teasdale. Good evening and welcome, Professor Teasdale.
Good morning, Basant. How are you?
Hey, good morning. Good morning, Roberto. How are you doing? You look good.
Excellent.
Well, it won't be very cold there in Miami. It won't be very cold, right?
Oh, perfect. This is the time of the year for 6 months now. It's perfect in Miami. No
Yeah.
rain, sun, and 70 degrees Fahrenheit. So it's perfect. This is why people move to Miami.
Yeah. Just 1 second. I'm getting a phone call. I'll just come back.
Sure.
So, Roberto, Ajay had mentioned to you, I think you got my mail, the way we are going to do it. Is that okay? So, the Graham is actually not in UK just now. He's traveling. So we have recorded his interaction with Franco. So once I will introduce you all, Franco's interaction with Graham, will play it, and then we'll have any question, then I will interact with you as we discussed. I don't know either anybody has joined. As Franco has joined, let me see.
Not yet. Professor T still is there. And
Professor T still there?
yeah, he has joined, sir.
Oh, okay, good. So I thought he
But-
was traveling. There's somebody, I think Franco told me he was going to Canada. He was not available. Very good. Can you see him, his face? I can't see.
He switched off his my microphone and video both, actually. We tried to communicate, but waiting for his response.
Acha, okay. All right. So yeah, he's on there, right? Okay, let me send a message to Franco. Let me see what's happening. Roberto, this is my young colleague, Dr. Abhijit, who is helping us with this webinar. So let me see, Franco, what is he doing?
Professor, you are mute.
I was just saying it's a pleasure that we met just a few minutes ago. Yeah.
Yes, Professor. Likewise. Yeah, Professor Teasdale is starting video. Good evening, Professor Teasdale. Can you hear us well?
Graham, we can't see your face. Your camera needs a little bit of adjustment. Is Roberto Hiros is there on this? You can say hello. If you see you, you are muted.
Roberto here. How are you?
No, he is muted. Graham is muted. Yeah.
We can only see the top of his head.
I know. Professor Teasdale, can you adjust your camera? We can't see your face. I don't know whether if he can hear us. He should be able to hear us. We have 2 minutes to go. Franco sent me a message, but he hasn't joined. I know why. Franco said 5 minutes back, he sent me a message. Abhijit, I cannot join from my laptop. I don't know why. I'm joined from my mobile.
In that case, you can what you can do is
I wanted to share some screen, some photos, but I cannot. It doesn't allow me to join. I don't know why. I'm joined from my mobile, where I can't. I don't think I can share my screen from my mobile. Can I?
You can share, sir. And what you can do is from your laptop, just click on the link on the flyer. With that, you will join as an attendee, and I'll make you a co-host from there.
Okay. So what is that link is where?
On the flyer, on the PDF of the flyer, on your laptop, please click on the link. And
let me see.
I'll make you a co-host.
No, link is link. Okay. Yes, let me see. But this never happens. I don't know. Yeah. Yeah. Okay.
Thanks, Franco.
Hello.
How are you?
Hi.
Roberto.
Hi, Roberto. How are you?
Very
Nice
well,
to
thank
meet you.
yourself.
Recording in progress.
So you have to mute one device, so then the echo will stop.
I think if you have the computer and the telephone at the same time, you'll get this funny echo. So I think you have to do one or the other.
I have left the mobile. I had switched on the mobile. Now I'm only on the laptop because I was not able to join from my laptop. Hi, good afternoon, Franco.
Good afternoon, Basant. Hello.
Okay. Thank you, everybody. We are on time now, so we're going to go live. Somehow, I don't know whether Graham can hear us because he's muted and we can't see his whole head. I don't know. We're trying to communicate, but I don't know whether he's hearing us.
I think his wife is trying to help him with the technology. You need a grandchild to help rather than.
I know.
How are you doing, Franco?
I'm doing fine. What about you? I mean, we
Doing
are
well.
again in the middle of a new story, but
Sure.
we can deal with it.
Sure.
Okay, Abhijit, can you see the screen?
Yeah, I can see.
Yeah, correct.
Okay.
We can see the screen.
Okay, we are on time, so we'll go on live. This is being recorded. Good evening in India, good morning in North America, Latin America, and good afternoon in Europe and other parts of the world. It's a distinct pleasure for me to introduce our guests today, two of the very distinguished mentors. Both are my heroes for a long time. And my very good friend, immediate past president of the World Federation, Professor Franco Servadi. Professor Servadi, as we all know, he is the professor of neurosurgery at Humanitas University and Research Hospital, Milano, Italy. And he is the immediate past president of WFNS and past president of Italian Neurosurgical Society. So he is going to today interact with, now we can see Professor Teasdale's face. Good afternoon, Professor Teasdale. You are muted. If you can unmute yourself, that would be good. Professor Teasdale. Professor Servadi is going to interact with Professor Sir Graham Teasdale of UK, who needs no introduction to any neurosurgeon in the world. But as it is customary, I would introduce him as the past president of the British Society of Neurological Surgeons, past president of Royal College of Physician Surgeons, Glasgow. He has been the awarded Knight Bachelor in 2006. And he's got the Distinguished Service Award from the American Association of Neurological Surgeons 2014. He was also the recipient of Burgess Sammy Medal of Honor, WFNS. Of course, all of us know with the father of Glasgow Coma Scale score. It's a distinct pleasure to invite you, gentlemen. And let me also introduce one of my great heroes and mentors, Professor Roberto Heros. Again, needs no introduction to this audience. Any neurosurgeon worth his salt would know him. Professor Roberto C. Heros is Senior VP, Vice President, and Chief Medical Administrative Officer, Jackson Health System. He's a professor and co-chairman of the Department of Neurological Surgery, University of Miami. He's also the founder of the University of Miami International Health Center. He has been the president of the president of the World Congress, and he's the honorary president of WFNS and past president of American Association of Neurological Surgeons. So the way it goes, we'll have an interaction of Professor Franco Servadi with Professor Sir Graham Teasdale first. So may I invite Franco to please start with this recording which you have done in case there was any problem with Professor Teasdale's getting into connected. So Abhijit, can you play the recording? First, let Professor Servadi welcome the guests and then say hello. And please, Roberto and Graham, you can also say please hello to the audience before Franco takes over.
Well, I think it's a great opportunity to express our gratitude to our mentors, and I am very happy that Bazan gave me this opportunity. Even if we didn't work together, we were very close, and I have learned from Graham Morth and from many others of my mentors. So I'm extremely happy to be here today and to be here with him, and we will see the interaction we have very soon. Roberto?
Well, I'm just delighted to be here, and it's a real honor, Basan, to be chosen as one of the mentors that you're interviewing. Is a particular honor also to chair this forum with Professor Teasdale, one of my great heroes in neurosurgery, somebody who we talk about almost on a daily basis with the rest. It's a real honor to be here with you. My pleasure.
I think, Franco, you can start because Professor Teasdale is still muted. I don't know if he can. Can you ask him if he can unmute him?
Well, I will send him a message. Okay, but we can start. I think.
Abhijit, can you play the recording, please?
Can you, Professor Misa, can you stop sharing?
Yeah.
There you are.
Yeah, there he is. Sound. Abhijit, no sound.
Open discussion between a mentor and there is a problem with the audio.
Abhijit.
We may have to start again from the beginning.
Sound is okay?
No.
The audio is a big problem. We don't hear the audio. The audio is disturbed. Probably, Basant, you can start further with Roberto, and then Abuit can solve the issue, the problems.
Abhijit, you are muted.
Yes, sir. Yes, sir. I'm just working on it. I don't know what. Let me just do it. Just a moment, or just give me a moment, please.
Surprised that he didn't get the Nobel Prize.
Any sound is coming?
Yes, better. Go back from beginning. From the beginning.
For this mentorship.
Play.
Hello to everyone. It's a pleasure for me to be here today for this mentorship session. Actually, this session is an open discussion between a mentor and a pupil, or alumna, as we say, alumni, in the largest meaning that we can have of this connection. So it's something very informal. Today, my mentor is Professor Graham Teasdale from Scotland. I think introduction to Professor Teasdale are useless. Every one of you knows him. What I can tell you that we are surprised that he didn't get the Nobel Prize for the Glasgow Common Score. it should be deserved. The Glasgow Coma Score has been, I think, one of the most important clinical tools in the last 50, 60 years. It changed the way in which we speak each other. Before, we had different scales and clinical assessment for neurological patients. Now we have one scale for all over the world. He had quite a number of awards. He was a professor for a long time at the University of Glasgow. He was the chair, the first chair of the European Brain Injury Consortium, where also I was representing Italy, my country. He was the first president of the Neurotrauma Society, the president of the British Neurosurgical Society. He received the Medal of Honor by many institutions, including the World Federation at the time in which I was president in 2019. So he is full of honor, but he is, I think, apart from a neurosurgeon, he's a very respectable person and a good friend.
Is the audio on?
Audio is off again.
A lot of what we want to talk about today reflects how people.
Man. So we just, the president of the British Neurosurgical Society, he received the Medal of Honor by many institutions, including the World Federation at the time in which I was president in 2019. So he is full of honor, but he is, I think, apart from a neurosurgeon, is a very respectable person and a good friend and a good man. So we just, I think, start asking, I will start asking Graham if he remembers when we first met.
Well, thank you, Franco, for that very fulsome and over generous introduction. I will perhaps just make one point before we start on the memories. You referred there to the Nobel Prize. Well, if any prize came, it should be to Tita and Jeanette, because it's very much a partnership. And in that, the senior partner was Brian, but he had the generosity to let me take the lead. And I think a lot of what we want to talk about today reflects how people interact with each other. And this is the basis of successful neurosurgical endeavor, that they are respectful and each contributes to this position. The benefit of asking questions, debating, was instilled in me from early in my career and in Glasgow. So we were in Cologne for an ACRA meeting in 1980 something, 84. And it was shortly after the CT scanning had come in, and as it more and more head injuries were scanned, then it found that some had extradurals that we didn't know about. And you presented a paper saying the conservative treatment of silent extradural hematomas. And the chairman of the session, a very senior German person who I won't name, stood up at the end and with outrage said, "Young man, you must operate every extradural hematoma. This abstract should be excised from the book. If you were in my clinic, you'd be excommunicated." And to me, that really exemplified the bad type of interaction can be between a senior person and a more junior person. And the role of a senior person is always to encourage a more junior person, to help them develop their ideas about neurosurgery, not to suppress them by the legacy of the past. So I followed your career with great interest in that time, and we walked many paths together.
Yeah, I remember very well that point. I mean, it was 84. I was only 33 years old. It was my first trip outside my country to present a paper. And we never could imagine that this paper would have been disqualified in such a way. So we are very grateful to you stood up and said what you are saying now. I mean, science is science. If you have data in clinical cases, you can respond with more data in more clinical cases. That was important. And there is just a short notice, Semmelweis, the Hungarian gynecologist who published in Lancet that by washing hands, the puerperal deaths were down almost to zero. Just washing hands before delivery was disqualified by the whole community of gynecologists and sent back in poverty to Budapest out of the Vienna University. And only 20 years later, it was discovered that he was right. So as our writer, Umberto Eco, says, never tell the truth too early. You have to know when is the point in which you can tell the truth. So this was really interesting. Another question, yeah, go ahead.
A short anecdote. The first time I presented the coma scale to the British Society in London, it was in 1974. At the end of the presentation, a neurosurgeon in Oxford, John Potter, who did a lot of work in head injuries, stood up and said, "Well, Graham, that's all very nice, but it will never catch on."
Yeah, correct.
Didn't take 20 years, fortunately.
Yeah, that's the same story. This was too early. Well, starting from this, we go back to you and to your career. How difficult was your career at the beginning? Because when we see a man who is famous like you, or when I travel the world as president of the World Federation, everybody thinks that we are like this. But at the beginning of the career, we all had a lot of problems. I'm sure also you had a lot of problems. So how difficult was your career at the starting point in Glasgow?
Well, to be quite honest, it wasn't difficult. It was great fun. I qualified in Newcastle, and it was there I became interested in neuroscience. And in those days, you carved out your own career. You applied for posts about 6 months a year, different specialties, and had a sort of roving look through medicine and surgery to decide what you wanted. So I was lucky to work for some outstanding neurologists. I then worked in London for a time, then in Birmingham at the Acton Hospital. And as this went on, I was really sort of thoroughly enjoying clinical work. And I became even more interested in head injuries and decided that I wanted to do neurosurgery as a career. Now, I applied for a job back in Newcastle to start my proper surgical training to teach anatomy, and which is the usual career path. And after the interviews, I got a phone call from the professor saying, "Well, Graham, I'm very sorry, we don't have a job for you." So I was a little bit upset. I know that in Glasgow, looking for lecturers in anatomy, and if you like, I can speak to the professor there. Now, my first reaction was to say, "No way," to dismiss it. But fortunately, I said, "Well, all right, I will do, and it'll only be for a year." So that I went to Glasgow to spend 1 year and never left.
Well, good story. We have a similar experience. I also moved to a place to be an orthopedic surgeon, the biggest institute in Bologna, Rizzoli, of orthopedic surgery, which back to 300 years of history. Then I thought the orthopedics are too inaccurate. You know, they move hands and they stretch. And I found someone who was using a smaller field of surgery, and I moved to neurosurgery at the last minute, just one day before I could do it. So life is sometimes unexpected, or drives you where you will not imagine before. Another question that it's many of us are asking, you have worked a lot for coma and for coma assessment. Then you moved to an interest that we will see, it was not only the only interest you had, but a strong interest in traumatic brain injury. How did it happen? How did you move from the study of the consciousness to the brain injury field?
Well, my interest in head injuries was actually stimulated in the first couple of years after I qualified while working in Newcastle. The professor of neurology there had a big medical legal practice with consequence of head injury. And he used to go to hospitals to see severe injuries and survive, and took me with him for interest. And he would get the early notes and try and work out what the patient had been like. And I don't have to tell you the kind of things you would find or not find. And he sort of used to throw his hands up and say, "This is useless, we need something better than this." And his approach was really trying to diagnose where the lesion was in head injury, which, if you know, is a kind of fallacy. But that interested me in the assessment of consciousness and in head injuries at the same time. Then after that, I worked in Birmingham, where the first trauma center in the world was, and it was staffed by trauma surgeons. And I was working there as a registrar, and we looked after the head injuries coming in. And again, I saw the difficulties of trying to work out things and communicate. So when I started in Glasgow, it was ideal in that Brian had already a strong head injury interest, and I was looking for some way to assess the patient. And my background in neurology and experience fitted well with that. And that I, was aware of the importance of consistency, because it depended on communication between different people. And in those days, the idea of observer variability was just beginning. But the coma scale was based upon successive studies of the variability with different approaches. We soon abandoned some of the traditional decerebratory cortical approaches. And what we ended up was, the very simple language. So they sort of interacted on the way through. Didn't move from one to the other. They were sort of hand in hand, interest in coma assessment and in brain injury.
My strongest period with you was the period where we were together in the European Brain Injury Consortium. And until that moment, there has been multi-center studies published, many of them from basically, apart from the 3-country study that you did with the Dutch. But most of the studies were published in America, from San Diego and many other places, the Marshall scale and so on, where the studies required grants, large grants, and difficult collaboration between different centers. In Europe, we were able to establish first a group of friends and then a group of clinical researchers, which published quite a number of papers almost without funding, just funding for traveling and nothing else. No funding for clinical research, or not many, at least. And we established, in a way, a system of working which was copied afterwards by the American Brain Injury Consortium and many other institutions. Which is your, how do you remember the experience of the Brain Injury Consortium?
I think it was a wonderfully successful and rewarding period. Just for history accuracy, the American consortium was conceived at the same time by Tony Momaru, and we discussed together the idea. So they were thinking about it, but we were more rapid in turning it into practice because we had the privilege of successful studies, for example, with nimodipine in head injury, which is a European study. And so we had a kind of core basis of people who had seen what working together meant and how it could be successful and useful. And we built on that. And I think that what we tried to do, and you might comment on this, was to convey the idea that the consortium was owned by the members. Although it had a steering committee, it was a committee on behalf of the members, and that they were those who could decide what it did or not. It wasn't a kind of one-man band or ego trip for one person, with people just giving their data away and seeing nothing back again. It was all owned by the members. And it comes back again to where I started. I think that successful things in life and neurosurgery depend as much on human relationships as on science and other factors.
Yeah, correct. And I think we have a good balance between clinicians, meaning neurosurgeons and intensivists, and the statistician. You know, sometimes I work with the Brain Trauma Foundation, and there you find yourself in the middle of too many statisticians, epidemiologists, you know, all this kind of, which is helpful to us. But the main issue is the clinical value of your production and how can people can use in the routine normal life. Yeah. Not, I think, on the top, only the strong evidence of what we publish. This is important, but also important, it's how can you use it? And I mean, we have seen that our production was in a way useful for the people.
Yeah.
Listen, and another question for you, it's just to enlarge a bit your neurosurgical attitude, not only for trauma and publication and research. I mean, which were, I know them, but I want you to explain which were your strong surgical skills during your career.
I was fortunate in being able to have a very strong neurosurgical practice alongside the scientific one. And this was again a reflection of human relationships, in that the neurosurgeons in Glasgow had decided that there should be subspecialization in the early 1970s, before it was popular. And by agreement, each of us would take one area and specialize in that and cross-refer cases. Everyone got something that was theirs, and by giving away patients, they got patients back. So it was a win-win situation. And so my special areas were pituitary tumors and acoustic neuromas. And that reflected my having done a fair amount of medicine before I did neurosurgery, and having an understanding of endocrinologists and being able to speak their language in a way that they felt safe. Having at a very early stage been to see Charlie Wilson in San Francisco doing particularly Cushing. So I had a practice for pituitary tumors. And the other one was in retrosigmoid microsurgery for acoustics and other basal skull tumors. And that reflected having gone again at an early stage to see Ted Kersey in Los Angeles, who was really the father of retrosigmoid macrosurgical treatment of acoustics. And he was an awesome character. He had immense patience and meticulous approach, not to do anything that would in any way compromise any of the cranial nerves. And that stuck with me. So I had these sort of two early experiences, and that fitted well with this area of specialization. So over about 25, 30 years, I was doing all pituitary tumors from a population of 3 million. And the majority of the acoustics. So that's, you know, I didn't bother to count them, but there must be hundreds in both categories. And the other thing is that I specialized in elective cases, which is very good for an academic neurosurgeon. Gives you a chance to plan life, do some operating, go away, come back. So it worked out very well. And you know, my colleagues were very generous, and it was a great teamwork. Another person who was a great help was, of course, Majid Sami, who I've known for many years. Tremendous role model and supporter in developing microsurgical treatment of acoustic neuromas and, of course, many other regions. And we have a really strong, enjoyable friendship.
Well,
Franco, hello,
Yeah,
Franco.
yeah.
Franco, can you hear me?
Yes.
Yeah, I just wanted to say hello to you and Professor Tisdale. This is Basan Mishra here.
Yeah,
I just can't,
hello to you.
Yes.
I can't stop but comment here about the Graham's, you know, the specialization, subspecialization. I think he is not going to be there, so it's a recorded thing. So I just want to make a point here. The 1985-86, when I was a registrar in Western General and Royal Infirmary in Edinburgh, you had an understanding between you and Douglas, and the residents from there who were interested used to go and learn from you microadenoma, basically Cossacks, which you used to do those times. I mean, you used to specialize in that, so you used to get all these patients referred. So I think your secretary used to inform our department when you had a casting, and then we used to, it was a very short distance, so we used to go see the case and come back in the evening, and I have done it many times. And thanks to you, we started before that. In fact, India, the microadenoma was not so commonly picked up because of investigation restrictions and so on. But when I came back, we kept on doing that, and thanks to you, we started doing many microadenomas. So I just make kind of acknowledge and thank you for your contribution to develop a pituitary surgery in my part of the world.
Thank you very much. Yes, we trained neurosurgeons from many parts of the world. And again, that illustration of how Douglas and I came to an agreement, and he would send the microadenomas across, both for the benefit of training and the patient, giving the patients the benefits of specialization. So again, an example of how relationships between people can benefit lots of other people.
Yeah. Do we have a recording now? Can we?
Yeah, it's
ahead?
going on. Yeah,
Yeah.
it's going on.
It's going on, sir.
Okay, thank you. So we heard from Graham his strong surgical activities, which was obviously combined with a very good, outstanding publication and participation to meetings, congresses, courses. So Graham's life can show you that you can do both. You can do surgery and at highest level, and you can do clinical and research at the highest level. Our last question is, you know that there is what they call it a neurosurgery cocktail, which is in the social media. It's in Facebook, and it's almost 24,000 neurosurgeons are all over the world are registered, which means almost half of the existing neurosurgeons. The World Federation has recorded 51,000, so 24,000 is a lot. And there is a strong section about young neurosurgeons who are participating to the chat, to the system of neurosurgical cocktail by asking advices for cases, discussing diagnostic approach, all this kind of stuff. But it's also a social media. So we also have questions to the public, to the people. One of the last questions was, who is a great neurosurgeon who publishes books and articles, who does many surgery, who teaches and speaks well in conferences, which was followed by, I do surgery nicely, but I cannot speak well in conference. I have seen many who don't do surgery, but speaks well in conference and workshop and attract them. Who is the best? And the answer, obviously, for 1,245 neurosurgeons was those one who do many surgery. So in a way, we obviously, I had a comment also, many others, trying to explain that these two attitudes toward good surgery, having scheduled surgery, elective surgery, traveling the world and publishing are not in conflict. Your life shows that this is true. So would you comment to the young neurosurgeons who are attracted by surgery and put it in conflict with clinical research?
Well, as you said, absolutely no doubt that it's possible to do both. You need a suitable environment and colleagues, but to me, the greatest neurosurgeons do both well. And if one thinks back, one of to Cushing, he was also a great writer. He published an autobiography and a very great writer. So I think that it's a false dichotomy to say you have to be one or the other. If one goes down that line, then there are risks. If all the person does is operate, then they will have a practice which is based upon the past. And one saw that in elder colleagues, that they didn't move with the times. And when I was training, the microscope was coming in, and some of the senior neurosurgeons could not use it, and became marginalized. So that one thing that academic work does is give you an open, questioning mind. And to do your clinical practice well, you need to have that mental approach. Conversely, if you are academic without clinical involvement, you can get into areas that are not relevant to day-to-day life. And I think that the two should be hand in hand, benefiting from each other and feeding from each other.
I think we cannot agree more. I think we are at the end of our conversation. I think we...
Franco, I just want to ask one thing before we wind up. I mean, Graham, what would you say that you would have done differently, if anything at all, if you do it all over again? I don't know whether Franco asked it.
Yes.
I will ask him. If you agree, Graham, I can ask.
Yeah, please go ahead. Please go ahead.
Well, I will, Graham, just to finish our conversation, is it anything that you would have done differently in your life from what you have done, even either before or later, during the whole part of your life, including some personal experience after you retired? Do you have any idea of a change, a big change in your life that you have not done?
Yes, yeah. I think it's not in terms of neurosurgical career and activities and paths there. In terms of the amount of time neurosurgery took out of my life. And there was a phase When I was around about 50, when I felt it was too much, particularly this, I described the academic clinical neurosurgeon, and it was a very busy, very hard life, and took their time. And I contemplated moving out of academic neurosurgery to a much easier, just operating neurosurgery job. And in the end, I didn't. And I accepted that, I was not, I had my, my genes were pointing me in both directions. So I continued that. But I sometimes look back and think, well, there'd be more time for my family if I had, they weren't neglected. We had a lovely family life, but that'd be the one thing. Things, it comes at a cost, and one has to sort of be prepared to take that. Now, of course, I've got grandchildren, and they're taking the place of the children I didn't see when I was in my career.
Well, that's a common sense that neurosurgeons are very expert surgeons, usually have more to do with nephews than with sons or daughters. It's something which happens. When I was working in a big emergency unit in Bologna, my son, he was 2 years old, was searching for me behind the table. Where is my father? Where is my father? Because he couldn't see his father. So he was searching for the father all around the house. So I think we have all the same experience. I agree with you. If I would have changed something, I would have changed with more time for the family. So I think it was a very fruitful discussion today, and I feel you really, I confirm, even if we are your age, we would say not that much, but we are all already mature, that I feel you a mentor, and I am privileged to have you as a mentor, even from distance, always, because we never work together. I never work with you. So I think having this discussion is important for our soul and for our future. And I hope it will help the young generation to watch less in the phone and listen more to what we are sometimes to good advices that come from the past. Thank you, Graham, for being with us.
If I can have one final comment.
Yeah, please go
ahead, please.
Yeah. This has been enjoyable for me too. And it's just to comment on what is meant by a mentor, which is different from what is meant by a coach or a teacher or role model. Because a mentoring focuses on the person being mentored. The focus is on the trainee, and the role of the mentor is to enable, support, promote them developing their lives on their own way so that they achieve what they want in life and hopefully at the end become better than their teachers.
Okay.
Thank you very much. Thank you for your time, Franco, and thank you so much for agreeing to do it. I hope you didn't mind spending your time with us, and I'm sure this will help many young neurosurgeons. The next generation. I have seen you working, so I know what you are. But there are younger neurosurgeons who would not probably have met you, who would not have known you, though they know all the work. I mean, the Glasgow Coma Scale. How can anybody forget? So, Franco, you can conclude. Then we'll come back.
Okay. I just.
Thank you. Thank you.
Yeah. I just thank Graham for being with us, and thank Vasan Mishra for giving us this huge opportunity. And I am very happy that we met together again, Graham, even on the web. I'm sure very soon we will be able to travel and see each other in front of a beer or a wine or whatever you want, any kind of drink. But we will have to party when this big problem we have with pandemic will be over. We are on the right way. Thank you so much again, Graham.
Bye, everybody.
Hello to everybody.
Thank you very much. Bye-bye. Take care.
Bye.
Abhijit, yeah. So thank you very much, Franco. There are some questions, but I think since Graham is not on, so we'll take that after my interaction with Professor Roberto Hiros. Franco, please stay around. Can you unmute yourself, Franco? You unmute yourself. Unmute.
I was unmuted already. I got again unmuted.
Yeah, you want to say a few words before we go on to, we go on? Okay, right. So this is my, Abhijit, can I share my screen?
Yeah, absolutely.
You see my screen?
Yes.
Okay, this is a huge moment for me. This is a distinct pleasure for me to interact with Professor Roberto Hiros. Before I go on to his eventful life journey, let me take this opportunity to quote one of his colleagues, a very good friend of mine, Jack Morcos. And this is during his the department residence were felicitating him. And there is a book published by the residents. And there's a foreword written by Jack Morcos. So I have talked to Jack, and he's quite happy that I quote him. And he writes about Roberto Hiros. I'll read that before I go on to a little bit about his life journey. And then I interact with him. So Roberto Hiros, MD, Professor, Program Director, and Co-Chairman of the department, dedicates this hour of every day to imparting all that he knows to his favorite people outside his family, his residents, his pride and joy. And what he knows is immense. What he knows does not fit in a booklet or a textbook or encyclopedia. But that alone is not why residents want to listen to him. They present and discuss cases. They get questioned, challenged, taught, encouraged, admonished, congratulated, or reprimanded. They are given references to read, biographies to learn, projects to complete. They either soar to peaks or crash into valleys. They hear about what could be done, what should be done, and what was not done. The neurosurgery they hear about has little to do with textbooks and a lot to do with character, that of their mentor. He carries passion and fortitude, conviction and righteousness to a level they have never seen before and unlikely to see again. They learn that no sacrifice on the part of the physician is too large if it helps alleviate patient suffering. No measure of effort is too small if it carries the slightest hope for recovery. They hear passionate appeals such as, "Is that what you would do if you were your brother or sister?" A sentence which I tell all my residents, and I follow that. So that appealed to me very much. And I quote again, "He is his first own enemy, his own judge and executioner. And his court takes no bribes, his army no prisoners." Jack writes so well, and very, very appropriately. His justice is harsh, but truth is on his side. When blame is in order, he often collects first, although opportunities to deflect always abound. "I was wrong to have done so, make no mistake about it. Whose fault do you think it is that this patient is in such a state? It's all mine. To err may be human, but to admit is divine." To this group of trainees, admitting wrong doing by their teachers is a rare enough, using this experience to its fullest extent for teaching purpose, with utter disregard to personal pride is simply unique. They have seen a gentler form of honesty in the other teachers before. They had not recognized that it was generally slightly contrived. If self-criticism and admitting wrongdoing among physicians is akin to stripping, most barely unbutton their collar. Some take off their tie, and few brave souls take off their shirts. Roberto Heroes, well, he stands out like a nudist in Tehran. How beautifully has he put it. So Roberto Heroes, unlike the average neurosurgeon in the world, many of us, had a very, very eventful life and a colorful one, I could say. He was born in Havana, Cuba in 1942. And this is his family with his parents and his two brothers. He's in the middle between his father and mother. He was an accomplished, most valuable football player way back in 1959 of Cuba. Now then the journey is much more interesting. He left Cuba for exile in 1960 when the communism took over Cuba. He was a paratrooper in the Bay of Pigs invasion, which was a disaster. He was captured. He was 2 years in prison. And then he was exchanged with an understanding between the Americans and the Cubans. And then he came back to US. He did his medical school at the University of Tennessee. He was the best graduate, the first in the class. And he also, just 1 year, I think he did residency before he joined the US Air Force as major. And subsequently, he did his neurosurgery residency at Mass General Hospital. This was his picture as a captain in US Air Force in Vietnam. And these are some of the pictures. Robert, would you like to comment these pictures of yours? What are these pictures about? Before I go to the questions.
I don't, go on. I don't recognize it. I'm not even recognizing the person you're talking about. Go ahead.
Oh, that is typical Roberto. So this is it with his wife. I'm sure you recognize her. And the professional career was, of course, remarkable. He was the director of cerebrovascular surgery. He was full professor at Harvard, Boston, at the Mass General Hospital. Then he moved to University of Minnesota at became the Lyle French professor and chairman of neurological surgery. And after that, he moved to University of Miami, where he is now, and he became the program director and co-chairman. He was the founding director of University of Miami International Health Center. And let me go on to ask some questions. And we heard what Professor Teasdale talked about, what is a mentor. So, Roberto, how does a mentor differ from a teacher for you?
Well, first of all, let me thank you for that undeserved introduction and for reading Dr. Marcos, my colleague, my brother, Jack Marcos, nobody can write it like him. It's just his ability to exaggerate, but it's such a wonderful English is incredible. Mentor. What is different from a mentor and a teacher? And I found a definition. Well, first of all, I think for those that do not know, mentor was actually a friend and a counselor of Odysseus, Odysseus, and his son Telemachus. So he was their counselor, and that's where the word mentor comes from. I found a definition. I am embarrassed to not be able to give it proper credit because, frankly, I don't remember where I read it, but I took some notes about this definition, and again, not from me, but so good, that defines the difference between a mentor and a teacher. And that is, a mentor is a teacher, but in addition, he's a role model and a humanist. He's a motivator. He's an ethicist and a moralist. He's confessor and fair judge. He's a rewarder and punisher. he's a co-learner. He continues to learn with his pupils. And the best example, I think, for example, Jack Morcos considers me his mentor, but I can tell you that I have probably learned more from him in many ways, particularly about surgery and surgical techniques, than he learned from myself. So a mentor needs to continue to learn with his mentees. And also a mentor is a loving authority. So I thought that definition was very comprehensive.
So that leads to the next question. As a mentor, what are the most important guiding principles that by personal example you try to inculcate in your mentees?
Well, I think the first thing you need as a mentor to be respected by your mentees is to have absolute intellectual honesty. You have to be honest, and your mentees, your residents, your fellows, your students will know if you're not being honest. They're smart enough and they can tell, and they won't respect you if no matter what else you do, no matter how good you are as a surgeon, what a good lecture you can give. If they don't think you're intellectually honest, they won't respect you. And you have to instill this sense of intellectual honesty in them. You have to teach them to recognize their complications, to talk about them openly. If you make a mistake at surgery and the resident is with you, don't say, "Oh, how did that happen?" Just say, "I did it wrong. You know, it's my fault." And don't bluff, and if you don't know something, don't be afraid to tell them not to be afraid in front of your colleagues, even in front of your mentees. If you're the mentor, don't be afraid to say, "I don't know." Don't try to bluff and come up with something else. And if you make a decision that, for example, they call you in the middle of the night to evacuate an intracerebral hemorrhage, and you're not so sure that it should be done or not, it's 2:00 in the morning, and you say, "Well, let's just treat this patient conservatively." And then the next day, somebody comes at 2:00 in the afternoon with the same hemorrhage and you evacuate it. Well, don't try to explain to the residents that, well, the one at 2:00 in the morning, the other one, the sodium was a little low, so I didn't want to. No, say, "No, I'm not sure which is right. And in this case, today at 2:00 in the afternoon, it was convenient to operate, but at 2:00 in the morning, since I wasn't sure that was the right thing to do for the patient, I prefer to stay asleep." So if you're honest, I'll respect you. Don't make up a reason that is not the real reason. I teach my residents, my fellows, I talk to them about scholarship and what it really means, and that there is a science about medicine, clearly, but there is also an art of medicine. So that the scientific method is important, evidence-based medicine is important, but we cannot become enslaved by it. We still have to use judgment. Still, each patient is different than the last one. So what the medical evidence or the evidence-based medicine may apply to one patient, but the other one has different circumstances, and the same that you apply to the last patient may not apply to the second. So yes, we must know the scientific method, we must know the science, but yet we have to use the art of interacting with the patient in order to be able to apply it intelligently to each patient. I teach my residents that they have to respect their patients and always treat them as if they were not patients. For example, if I see all the time in the hospital, nurses, patients walk in the room, some distinguished individual perhaps, and call them by first name, where they would never have called them by first name if they meet them in the business place or in a bank or in a restaurant. But somehow they think that now that this person is a patient, his value decreases, so to speak. at times I see that somebody who normally would have been reading The Economist, or I'm sorry, I have to shut that up. Be reading the Economist, Wall Street Journal, and then I walk in the room and they have a cartoon, a Mickey Mouse cartoon in the television. No, that's not who this person is. Treat that person with the respect that they deserve. When they walk in the room, no talk with anybody else, no telling me about the laboratory values or anything like. When we walk in the room, only the patient. All the attention goes to the patient. If they're walking on the hall with a gown that has their back and their buttocks exposed, give them another gown to cover the back. That kind of respect to the patient, I think, is very important. I tell them to be, I try to teach them to be time and cost efficient, that to do for each patient only what that patient needs and no more, and not do extra things or order extra tests for medical legal purposes or for medical legal protection. That never really, only what the patient needs and not anymore for any other reason. And then I tell them about the pride of being a neurosurgeon. You know, there's nothing like it. I mean, there may be other careers like being the head of a Napoleonic army that may have, you know, may have been good at that time with feathers and a sword and so forth. But nowadays, I see there's no career like being a neurosurgeon. So I teach them to be very proud. That doesn't mean to be arrogant, but to be very proud. We deserve the respect that we have because we've worked hard for what we are doing. And these are the main principles that I try to teach my residents, my mentees.
So that's the mentoring has been one of your passions. I see that this is your, when you were the president, this was the presidential address to the American Association of Neurosurgeons. And this is what you said then in your slide. Intellectual honesty. Our trainees will forgive almost any of our weaknesses, but they will not respect us, as you said, as mentors if they perceive us as being intellectually dishonest. So the honesty has been the core value, I think, of Roberto Heroes, and my respect to him actually goes back many, many years, listening to him many times in many meetings. Though in our part of the world, we have this kind of thing as gurus, where you might not be a direct disciple, but you can still be a disciple. So similarly, I have been your disciple because I have, kind of learned from your thoughts, your views over a very, very long time because of similar interest in cerebrovascular surgery. And I almost remember your quotes in when you talk about AVMs and as the reason of not making a person a patient if you're not operating. I still remember one of your, I can't remember where, but I have read your one of your articles where you've said that if you're not operating AVMs, we all know that many of these AVMs can probably better be left alone than do anything. And you write there, don't make a person a patient by telling him that you have a grade 5 AVM, so some of those things, quotes, I still remember. Yes. And so would you like to comment? I mean,
yes, I mean, it's always, that's what this approach to each particular patient is very important. There is the worst thing that we can do for a patient is telling them, look, you have a terrible problem. It's very serious. This is deadly, but I can't do anything about it. So that's just a way of making that patient worse. And the patient is so, yes, after I wrote an article that my fellows looked up the results of my initial series of AVMs and the late results. And when I saw the results of my operating on very high grade AVMs, particularly grade 5 AVMs, and I realized that half of those patients, almost half of those patients, were still wrecked, really. even 6 months after. So it wasn't just transient morbidity, it was permanent serious morbidity. And then I said to myself, wait a minute, what justification did I have to operate on a patient, knowing if I had known that there was almost a 50% chance that I was going to harm this patient and make him an invalid, would I have ever operated on one? So I quit operating on those high-grade AVMs. But then I would tell the patient when they had grade 5 AVMs, I would come in the room and tell them, I have good news for you. You have one of these very, very large arteriovenous malformations that does not need to be operated. So you really don't need surgery. And well, doctor, but what if it ruptures? I said, well, I tell you what, I have never seen an AVM exactly like yours that bled. So, oh, really, doctor? Never. Yeah, and of course, no two AVMs are. So I wasn't lying, but I would say, no, I've been around for a while and I've never seen one just like yours that has MRS. So, oh, doctor, you don't know how relieved I am. And so that's been my approach with patients. That's not evidence-based medicine, but is humanity, I think.
But that's now evidence anyway. So now what you said many years back, now that stands to facts, to science, that the grade 4, grade 5 AVMs are probably better left alone, especially the unruptured ones should not be treated. I mean, should not be intervened anyway, so other than medical management. So you were not very wrong because of your extensive practice. Similarly, I mean, I would say, like, I'm privileged to be a member of a very select group of neurosurgeons, which is World Academy. And when Roberto presents something, we all, were very, very intently listening to it because he comes out with truth. I still remember one of your presentations where you talked about which are the veins which can be sacrificed and what has been sacrificed without a problem. I don't know whether you remember because you've been presenting all over the world. So, but I still remember.
Yeah, no, that is important because there are two papers, and about the veins, but also under which circumstances sometimes it's better to just do a little resection of silent brain in order to get to a deeper lesion without having to retract a swollen brain. And the problem is that we hear from our idols, the brain is sacred, you never resect any brain, always work in the subarachnoid spaces, don't touch the brain, and don't sacrifice any veins. All veins are important, you must not sacrifice any veins. Well, you can't have a good pretemporal approach to get to the basilar area without sacrificing one of those little veins that connects the sylvian fissure with the sphenoparietal sinus. And I've done it routinely and I've never seen a problem for it. So I talked about that. And then I've talked many times about resecting a little bit of brain, maybe in the inferior temporal gyrus when the brain is swollen and you want to do a subtemporal approach to go to an incisura instead of trying to retract and fight with the brain. We'll resect a little bit of inferior temporal gyrus, or in an aneurysm that is stuck to one side of the brain. When you get to it, instead of trying to stay within the subarachnoid space, just resect a little bit of brain around the aneurysm if it's in a silent area, in order to not rupture the aneurysm and have a major problem. So yes, I've talked about those things that I think, and I think it's very reassuring to the younger neurosurgeon to see that somebody with experience sometimes does sacrifice some veins that can be sacrificed, or resects a little bit of brain to, instead of retracting a swollen brain. And so yes, I've talked about that and I don't regret it.
So, Roberto, this is a photograph of yours, which I found you in the middle. Is it the American Association? Do you recognize this?
I believe so. I think that was a picture. Yes, because here is the executive director. So this is the American Association of, this must have been the executive committee, the board of directors of the AANS.
Okay, before I go to the next question, let me, okay. So how was the beginning? Let's go back again to the beginning. How was the beginning of your career, residency? How different is it, or was it compared to the residency program today, which you lead?
Well, in the United States at that time, when I was a resident, there was a still we had an attitude that patients that were less fortunate and did not have insurance really belonged to the residents, so to speak. So that when I was a resident at the Mass General, there was, by the time I was chief resident, there were my patients. The faculty would come to one of my surgeries only when invited, so to speak, when I thought I needed help. And arrogant as we all were during that time, very few times did I ask for help from my faculty. And I'm sorry, I still remember the people that as a resident I hurt because I didn't ask for help. Nowadays, things have changed. Here, where I've been working for the last 28 years, 28 years, in Miami at Jackson Memorial Hospital, all patients are treated equally. So we may have in one room an indigent patient that lives, a homeless patient that lives down under the bridge in here. And in the next room, I may have a millionaire from South America that came to see me, and they're taken care of by the same nurses. Their room looks identical. And when I go to the operating room, I really don't know who is who, or try to ignore who is who. And I let the residents do what the residents can do safely. And if they cannot do it safely, and I have to do it, I do it myself, whether it's an indigent patient or again, a VIP from international VIP. So that's make me feel a lot better about, and I think that our residents appreciate the fact that they're not yet completely independent nowadays, and that they still need supervision for every case until they finish. So that's been the major change that I have seen in the residents over the last 45 years. That concept that their patients are different depending on their payer status has disappeared, which I think is a very good thing.
So, Robert, who were your mentors? Did you have any mentors in neurosurgery, and who influenced you most?
Many direct and many indirect mentors. And incidentally, you have been an indirect mentor because I have watched your presentations, I have watched your videos, and I have learned a lot from you. You may not know it, but that's the truth. So many mentors, but some that I remember with particular fondness. And when I was a resident, my most important surgical mentor was Dr. Robert Hodgman. And the reason one of the reasons that he was so important for me is because I could never be like he was. He was an incredibly patient man. He was very slow as a surgeon, and the reason he was slow is not because of lack of aptitude, but because he took every conceivable precaution as if he were doing that operation for the first time. And I could never be as patient as he was, but I admire him so much because, and frankly, I still think he's the best neurosurgeon I have ever seen. Why? Not because he was technically the most adept or the most facile, but because his patients did so well. He had very few complications. In fact, in complication conferences, Bob Hodgman always fell asleep because he really didn't have complications. I was the star of the complication conference at the Mass General when I was on the faculty with him. And the reason is that he just was so meticulous, so careful, and also in caring for the patients. I remember when I was a resident working with him, every time I come and tell him, "Oh, Bob, your patient," he would say, "Yeah, I know." He already knew. He was ahead of his residents in terms of keeping up with his patients. And of course, worked very, very, very long hours. And I'd never been able to have that patience. I've continued to take shortcuts sometimes and be sorry for it, and wish I had been like him. Now, the other mentor that I remember with particular fondness was essentially an intellectual mentor, Dr. C. Miller Fisher, the famous vascular neurologist. So he was really fantastic. I think the best neurologist of his day, in my opinion. And he was a great teacher, extraordinarily patient as a teacher. He had this Socratic way of teaching. You know, he would say, "Oh, really, Roberto? That's how you believe? Oh, that's interesting." And I remember it was typical. He worked very long hours, like I did at Demasian. And I remember that every now and then, after I finished surgery at 9 o'clock, I'll be making rounds. And I see Dr. Fisher in the hall, and I would be tempted to ask him a question, but then I look at my watch and say, "Oh gosh, it's 9 o'clock. I better not ask him a question," because he would say, "Oh, why don't you sit down, Robert?" And then the way he would, I remember one time, for example, I was going to do I think a vertebral transposition for a subclavian steal syndrome. The patient had intermittent symptoms in their subclavian steal syndrome. And I remember that Dr. Fisher saw me in the hall and had heard that I was going to do that. And he said, "Oh, Roberto, you're going to do this?" And I said, yeah, great surgery. And he said, "Oh, really? And you're going to do it to prevent a stroke. Is that right?" And I said, "Yes, sure, of course. That's correct, Dr. Fisher." And he said, "Well, that's interesting." He said, sit down, Roberto," he said. And then he'll pick up a little booklet and a pen and said, "Now, I'd like to have the name of those patients that you know that have had a stroke from a subclavian, because for 35 years I've been looking for a patient that had a stroke. So please let me have them." Well, so from that, I mean, it took 50 minutes instead of 1 minute, but I never forgot the fact that no, these patients have intermittent symptoms, but rarely, if ever, do they have a stroke. So that was Dr. Fisher's Socratic way of teaching. But his knowledge about neurology and stroke neurology, and the certainty that he had of the neurologic examination. For example, with cerebellar hemorrhage, he would be very upset if we took a patient to get a CT scan who had a typical syndrome of a cerebellar hemorrhage. He would say, "Why didn't you take that patient directly from the patient had an ipsilateral facial palsy and the eyes couldn't move that way, and he had a sudden headache. Why did you have to have a CT scan?" He had that certainty. So I learned very much. In fact, he was the person that made me go into cerebrovascular surgery. It was my respect and admiration for his knowledge of neurology, the nervous system, and how it works, and for his way of teaching. And then I've had many indirect people that I have learned from that didn't necessarily work with, like yourself. And one that I remember with particular fondness, and I just mentioned him, is Dr. Drake. He remembered every complication that he had. He even remembered the name of the patients. I remember my complications, but frankly, I can't remember the names. I remember the face of the patient, but not the names. But Drake could remember the names, remember the complications. He'll talk about them, and tremendous wisdom. And you would ask him, "Well, why do you do this, or why don't you?" And he said, "Well, but I remember one time I didn't do it, and this is what happened to Mrs. Such and Such. She came from Iowa, and I wrecked her because I didn't do this." And so I visited him about 3 or 4 times, and I learned a tremendous amount from Dr. Drake.
So I can't agree with you more. I was fortunate to have spent some time with Charlie Drake because he was a visiting professor in my institute. You were also a visiting professor in All India Institute of Medical Sciences, which I'm an alumni. Of course, when you came, I had gone away from there. But when I was a resident, Professor Drake was a visiting professor, and he spent some time with us. So yes, that is something which was very typical of him. I still remember we had a patient, this was in early 80s, and we had a patient of MCA aneurysm which had bled, and patient was hemiplegic, aphagic, left side. We wanted to see him operate, and that was the patient available. And he was very reluctant to operate because he said, you see, the quality of life, which in India, I mean, that concept, that time, of course, now all we are very concerned about the quality of life. In 1980, we were much more concerned about saving a life rather than quality of life. And he was very, very reluctant. And then he spent hours with the family explaining what is the advantage of not operating. And finally, we somehow forced him to operate because we wanted to see him operate. But that meticulous time discussion with the family and importance of, the talking. And the other thing is remembering your complication. I mean, this is something very close to my heart. All my talks I say, no selective amnesia. That's my last slide. You forget your success, but don't forget your complication. Like you said, you remember the faces. I remember the faces of every single patient which I have either, damaged or the patient has died. And that's the only way to go forward. I can't agree with you more. There's such a tremendous thing you said for the young neurosurgeon. Remember your complications. That's the only way to go forward. So, Roberto, do you have any heroes other than neurosurgeons who you looked up to?
To be honest, my life and my career have been so focused in neurosurgery that really, of course, I was very interested for a while in military issues, and I don't want to get into that, but I owe this country so much. This country has done so much for me, and of course, I'm a great admirer of people like Ronald Reagan and many others. I'm very conservative, and I do keep up with politics, and so that's a hobby of mine. But in terms of other hobbies, I really don't have any hobbies. That's why now that I cannot really do the things that I used to do, I'm fortunate enough to have somebody like Jack Marcus, who I can refer these patients, and because now I know he can do these things much better, not only better than I could do it now, which I probably couldn't, but even better than I did it when I was at the prime of my career. It's just such a pleasure. I can't tell you what a pleasure it is to be able to retire, and yet to retire from surgery, which I'm practically retired. I do some simple cases every now and then. Because I have no other hobbies, I've taken up a job as an administrator, as a chief medical officer here, which keeps me at Jackson, which keeps me entertained, keeps me busy, and in addition, keeps me around the hospital so I can drop in the operating room every now and then to see Jack Marcus operate and say, wow, it's so great for a teacher to see an alumnus who now exceeds what you taught him to do. Now he can do better than you could ever do it. And that gives me such a pleasure, to have a legacy. I know that it won't, that just because I can't operate and do these things anymore, that there's still somebody that I contributed to their training who can now do it even better. So in that sense, it's a pleasure to still be able to be around. And for those who don't have a hobby, I can assure you that getting one of these jobs that keeps you somehow involved in the hospital, or hospital administrator or president or anything like that, is very useful. It'll keep you from being in a rocking chair at home or going to a nursing home, let alone to play bingo every afternoon at a nursing home. This is much better what I'm doing now.
So, I mean, like you, Robert, everybody knows that you always called a spade a spade. Did it bother you? Did it affect your journey?
Never bothered me from the very beginning. I felt that I had enough complications to be able to report them. I had because of what I did, of course, difficult AVMs, difficult aneurysms, difficult skull-based tumors, plenty of complications, and those are the cases I remember. I mean, the ones that did well and went well just make you feel great for a day or two. You feel terrific, but then you kind of forget them. But you don't forget the ones you hurt. And I thought that sharing that experience, both in the literature and in meetings and talks, sharing that experience with others was a way of gaining something from that unfortunate experience of that patient, teaching others that what you did wrong so that they can avoid it. And some of the most rewarding papers that I have written have been very simple papers of a complication. For example, I remember a lady that had a small aneurysm in the paraclinoid region. And it was small, so I didn't pay too much attention to the fact that the preoperative angiograms showed that she had an isolated circulation of that side, no anterior communicating. And because the aneurysm was small, I didn't expose the neck, which I always did for larger, the carotid in the neck. I always did for larger, more complex aneurysms. This was very small. And I started drilling the anterior clinoid, aneurysm exploded. And unfortunately, then I had to pack, stop the bleeding, but occluded the carotid by overpacking, and the patient had a major stroke and died. And then as I was torturing myself thinking about this case, I looked again at the angiogram and realized that the aneurysm, paraclinoid aneurysm, but it wasn't pointing medially towards the optic nerves, but laterally, kind of. And then the top of the aneurysm was flat. And I said, well, this is not a normal aneurysm. And the reason it was flat, it was against the clinoid at the top of, and then to make it even worse, and make me feel even worse, I looked at the preoperative CT scan, and on the bone windows, you could see a hole on the anterior clinoid. So the aneurysm had eroded the anterior clinoid. And of course, when I started drilling, I drilled right into the aneurysm. And so I published that. I called it subclinoid aneurysm and described the characteristics of, and I can tell you that 5, 6, 7 neurosurgeons have stopped me in a meeting. In fact, one called me specifically to tell me, I am so thankful that I read this article because I recognized before surgery an aneurysm like this and took the appropriate precautions and so forth. So that's very rewarding when somebody tells you, look, thanks to you, I saved a patient or didn't hurt a patient. That, very, very rewarding. So no, I'm not sorry that I ever wrote about complications. I think it's being a good, important part of my career.
So you were also, I mean, in your early days, you were captured, you were incarcerated, and how terrifying was that experience? A little bit other than neurosurgery.
Very few things are terrifying when you're 18 years old. So you find a way to be excited about life in general, even if life is in prison. But I was very lucky because, first of all, there were about 3 or 4 things that made my time in prison really bearable and not too difficult. The most important one is that I wasn't tortured, physically. That would have been a problem, but I was not one of the leaders of the invasion, so nobody bothered to torture me or forced labor or anything like that. The second thing is that I had no dependents, and that was very important. I had no wife, children at that time. I think the people that suffered a lot were people that had dependents. And the third thing is that I just did well during the fighting time. In other words, I did my job and above and beyond. So I had the respect of my colleagues for having, even the few days of fighting kind of defined, in the Latin world, the macho thing is very important. So it was very important that you did well and did your job and exceeded that. So that made that time actually not seem, as I looked at it throughout the years, retrospectively, not seem a bad time. Also, I had the opportunity to read a lot during that time. Fortunately, we had no political books, but I could read about a number of things and became a reader at that time. So I did not have a bad time. No.
So what's your
done without it, but I did not have a bad time.
So what's your relation today with Cuba? Is it good, bad?
Yes, I mean, it continues to be a very repressive communist regime. I haven't gone back, and the country has changed completely. Cuba was a very, very prosperous country before Fidel Castro took over. Cuba was probably by every index of prosperity, one of the most prosperous Latin American countries, among the first, second, or third in many indices of prosperity and development. Now it's among the last ones from Latin America, comparable now to Honduras, Nicaragua. The only country that is definitely worse than Cuba now is Haiti in Latin America in terms of all the statistics. So that's what a communist government can do over 60 years now. Can completely change a country from a rich, prosperous, happy country to a miserable, very poor country, repressive. So no, I haven't gone back, and I don't think I will.
Okay, Roberto, so let's last two questions. Would you do anything differently if you have to do it all over again?
Well, I was thinking about that as that question was asked to Professor Tisdale. And I have the same answer, to be honest, that my children, I've had two older kids and then one that is a little younger. And with the older kids, I did not spend the time that I should have. I did not go to their soccer games or to frequently miss their football games, soccer games. I would come home and work, bring a briefcase full of papers and things to. And when I look back, out of whatever 200 or so articles that I have written, I can tell you that I could now select probably 20 of those that were worthwhile writing. And the rest of them were written just for the purpose of academic productivity, promotion, to become a professor sooner than my time. And it was a waste of time. They didn't help, at least 150 of the 200 papers or so I have written did not help anybody, did not help me, have been totally useless. And yet they took the time that I could have spent during those days with my older kids. And I have noticed the difference because the youngest one is about 20 years younger than the oldest. And I have not missed a single game of his little water polo, not little anymore, it's in his 20s now, water polo star, and I would fly wherever. I didn't miss one of his games because I didn't have any longer to spend the time building up my academic career. It was already done. So I could, and if I had done that with my older kids, yes, my academic career would have moved slower, at a slower pace. But now when I look at the older kids, I feel guilty that I didn't spend with them. Fortunately, they've turned out all right in spite of me. But I should have spent more time with them, more time with the family.
I think this is a problem, and there's a question. We'll come to that later from one of our audiences. But the last question to you before we take the questions or comments from the people who are listening to it. What is your advice to the current generation of neurosurgeons? We just heard you that you would have probably spent more time with family and do more useful publication rather than only publication. So what would you advise to the current generation of neurosurgeons who are listening?
Well, I would tell them that they're very fortunate that there is a great privilege to be a neurosurgeon. Again, I would not choose to do anything else, even if given the choice of being anything, even president of a country. This is what we do is so relevant, you know, that, and in fact, now that I am not doing, you know, high-level neurosurgery anymore, one of the things that I miss now when I go home every night and I say, you know, I haven't done anything relevant today. I haven't made a difference to anybody. I haven't, you know, not a day goes by as neurosurgeon that you don't do something that is relevant to a patient if you're doing clinical neurosurgery. You know, if that operation that you're doing today had gone differently, the patient could have done better or worse so that everything we do in neurosurgery is so relevant. It makes such a difference, and it's such a privilege that our patients allow us to put their lives in our hands as they do so generously and trust us. I can't imagine of any more rewarding profession than to be a neurosurgeon.
So Franco, can you unmute? I think both of you, I think Graham is not there. So there is a question. I think it's a very important, but it's a very common question. So what is your call on a perfect work-life balance? Both Franco and Roberto, can you answer that? I mean, I don't know how to answer that, but please go ahead.
Could you repeat the question? Because
what's your call on a perfect work-life balance?
We both say
I'm taking notes, Franco. So
well, we both. I think we say the three of us, myself, Graham, and Roberto. We say the same, that we were not able to balance our life at the beginning of our career. All of us. I have the same experience as Roberto. Moving faster to academic career costed me not to see enough my children, and this was wrong. And as I told you, you see the nephews when you are older, but you don't see your child. So the advice is keep the family important and think about your family. When you are thinking about staying in the hospital out hours or going home with homework and being in front of the computer for hours, you think also that you have a family and you love your children, and this is important. This is the first step for an enthusiastic neurosurgeon, because as Roberto said, neurosurgery is fantastic. At the beginning of our career, but even now, we are enthusiastic about our profession. And very often we forget that the family is important. But after that, we are very sorry that we didn't remind ourselves.
Roberto?
No, I have nothing to add. Again, if I could do it over again, if I would think about, okay, I'm going to sit down tonight and do this and write a paper instead of spending time with my children. If I had thought, well, okay, but the paper I'm going to write, is this really going to be useful to anybody? Is this going to really make any contributions to the field? And if not, then don't do it and spend that time with the kids, with the wife. That's all.
So it's a genuine problem, much more, I think, in countries like mine, because the number of neurosurgeons is much less, the number of patients are much more. So unfortunately, even if you want, many of us have gone through that and don't see our children growing up, like Frank was said, children searching for their father. It's a common place story in India for not only me, but many neurosurgeons in early their career, even late into their career. But as Roberto said, I have two sons. Definitely, I spend a little more time, little more, not much, with my younger son than on my elder one. So that is something probably you would do, you would like to do, but it's difficult. I can tell you it is much more difficult in my country because the workload was so much more. So sometimes you don't have a choice. But obviously, looking back, you would probably say that, yes, I could probably cut down something and then spend time with my family. There are many, if you go to the chat, there are many people thanking for having listened to this, the mentors and Franco. And there is a comment by Dr. Mathuria, who is a vascular surgeon, senior vascular surgeon from India, commenting about the anteroclinodal, the hole in that and the risk of rupture, which he also had identified. He was one of our National Institute's chair of postgraduate institute and a very good vascular surgeon. So there is one more thing which I don't know, because the question is, till what age would you operate? Roberto, you said that till what age would you be operating?
I think is difficult for everybody. Look at Majid Sami. He's in his 80s, and apparently he's still. He tells me, and I believe him, that he's still as good as he ever was. I was not. Now I'm 80. When I was probably 74, 75, I began to notice that I couldn't do the things that I used to do. It began with a bypass, with a microsurgical bypass. And I remember that it must have been when I was 73, 74, I had done an anastomosis, and it had been difficult for me to do it. And at the end, it did not look right. There was some stenosis. And I said, oh my God, I have to redo this. And it was such a torture mentally to have to redo it. And I would say, well, maybe if I just leave it alone, it will be all right. Finally, I redid it and it was okay. But then I realized that, why, if I have somebody, a young colleague like Jack Marcus that can do it, and why would I do this? And the same happened with complicated skull-based tumors. I just didn't have the patience. By the time I had been operating for 6 or 7 hours, my stamina wasn't the same as it was. So I think that age is very different, treats people very, very differently. And I know that when I was in my early 70s, I began to not be able to do the things that I used to do as well as I did. But others continue to do it in their 80s. And again, I keep quoting Majid as a prime example of that. I don't know how old Majid is, but he's in his 80s, certainly. And apparently he still can do 3 or 4 acoustic neuromas in a day. So it's different for different people. I think what the important thing is and the blessing that I had, and that I hope most people have, is that your mind doesn't deteriorate faster than your technical ability. So you're still able to recognize that you're not the same as you were. It is a problem and unfortunately I've suffered through that problem with an older person who was my senior in another setting, who we just had to take one operation at a time from him. Okay, now you can do these, but not these. And if you do these, you have to have somebody else crawling with you. And we had to, little by little, piece by piece, take. Unfortunately, that hasn't happened with me, and I'm very grateful. So, Franco?
So there is one question from Dr. Nicole. His question to Dr. Heros, please, what would you advise to medical students in developing countries interested in this field? It must be from Latin America. The name is
just to pursue it. I think pursue your dreams, follow them. It is harder, no question about it, that it is harder to get good training when you come from underdeveloped areas, and certainly from Latin America. It's harder for but there are superstars, and many in South America, certainly everywhere in the world. So it's doable. And I think the important thing is not to think that the only place that you need to go to the United States or to Europe to train, that you can have excellent training. There are excellent neurosurgeons elsewhere in the world, so that not being able to obtain a residency in neurosurgery in Europe or in the United States is not and in India, spectacular places. I mean, I remember being so impressed and almost I felt so humbled when I was operating at Ames with Dr. Mehta, who was the professor at that time. And so I'll be operating one room and he was operating in the other. So I had the opportunity to watch him operate and how much better as a surgeon he was than I was. He was able to just handle anything. So the kind of training that you got, for example, at Ames, is far superior than what many of our programs offer here. So if anybody wants to be a neurosurgeon anywhere else in the world, pursue it. Sometimes the road is long and hard, but it's worthwhile.
So before we leave, there is a request by Dr. John Bennett, who is a neurosurgery TV he is organizing. If you go to the chat for a couple of minutes, if you can join him in the lounge, Roberto and Franco, that is in the chart. Can you see the chart?
Yes,
There is a link.
I have opened the chat.
Yeah, there is a link by by John Bennett inviting us to the lounge for a couple of minutes. If you could join, and thank you very much, everybody who's listening. It's a pleasure and privilege to have the giants, the heroes of many of our the generation of neurosurgeons, and also very good friend Franco, to have made it possible to get the Graham Teasdale agree to this, to come to this interview. Thank you very much. And
I appreciate it very much. I'm going to have to leave. I have a meeting that is waiting for me, and I appreciate this opportunity. It's been a great honor and a great pleasure and fun to be with you. So thank you very much.
Thank you. Thank you, Roberto, for doing this. It's such a privilege and honor to be here. Bye-bye. Bye. Franco, would you join this?
As you know, I have another meeting also.
Yeah.
It's a problem. Then the link disappeared, actually. I have a link with a video which explains the concept.
No, just above that. Just the message where the link is there. We just say hello and then exit, I think.
As you know, I have another meeting.
Yeah.
It's a problem. Then the link disappeared, actually. I have a link with a video which explains the concept.
No, just above that. I think it is repeating the same thing, whatever you said. Just the message where the link is there. We just say hello and then exit, I think. I think we are in the lounge. I don't know. Anyway, thank you very much, everybody. I think there is some technical problem. We can't join.
As you know,
so we'll have to exit this one and then join again on the link.
It's a problem. Then the link disappeared, actually.
So
I have a link with a video which explains the concept.
No, just above that. Just
copy that link.
I think
copy that link and paste it and
whatever you said. Just the message where the link is there. We just say hello and then.
So I close this meeting, sir.
I think we are in the lounge. I don't know. Anyway, thank you very much, everybody. I think